This videotape is to discuss the rather controversial subject of endometriosis. That's the lining of the womb being found on the surfaces of the pelvic organs or other parts of a woman's pelvis, and it's alleged to cause chronic pelvic pain. The premise of this video is that the ectopic endometrium is largely irrelevant. It's irrelevant to underlying injuries to pelvic nerves, which are the source of most pain, and the best management would be to prevent those injuries. Now, this isn't something that every gynecologist is going to subscribe to, but by the end of this videotape, I hope you'll believe that it is almost self-evident. This work was done largely in Shanghai Jiao Tong University, under the leadership of Professor Huang Hefeng, FRCOG. This is 16,000 deliveries in the maternity unit. This is the outpatients department. This is the service delivery center, all sitting on top of the Shujiahui underground station. So it's very convenient for our patients to come to and fro from the hospital. Now, to understand endometriosis, you need to understand a little bit about laparoscopic anatomy in a woman's pelvis. And a laparoscopy is when a telescope is placed through the tummy button or umbilicus into the woman's pelvis so that they can inspect the pelvic organs. This is what it looks like in the operating theatre. And this is what you see. This is the uterus, one fallopian tube, another, an ovary, and then these very important ligaments are your uterosacral ligaments, and they suspend the lower genital tract and also importantly, deliver the nerve supply to the uterus and fallopian tubes, which run down these lanes here. And what is significant in this video is that if the uterosacral ligaments are injured in any way, shape, or form, then it's a fair bet that the nerves inside them are injured as well. And we'll come back to that in some detail in a moment. This is what endometriosis looks like. If you look in the top panel here, there are 4 large deposits of ectopic endometrium with an inflammatory reaction behind them. You see that they're adjacent to or on the uterosacral ligaments, and there's reasons for that. And then here we have red, brown, and blue patterns. Here we have some endometriosis in the top left-hand corner here with a large reaction to it, associated with very thin uterosacral ligaments. And then here's lots and lots and lots of endometriosis with very thick uterosacral ligaments. And the reasons for all of those appearances will become clear in just a short while. This was all first discovered by John Sampson of Albany, New York. Sampson, in 1921 through to 1929, published a series of 4 very important papers. And he set out this traditional view of endometriosis where endometrium, or the lining of the womb, passes, instead of passing out of the body like this along the red arrow, passes upwards and backwards through the fallopian tubes to be shed onto the pelvic surfaces, as we've just seen. It attaches to different anatomical sites, but he didn't explain why that it attached to these particular sites. And it was alleged to cause chronic pelvic pain, though no mechanism was put forward for that pain. So what we think is a better view of the situation is this, and these are pelvic autonomic nerves. And when they were first discovered by Robert Lee at St. George's Hospital, they looked like this. This is the sacrum that you sit on. Here's the pubis. Here's the uterus, cervix, vagina, rectum, and bladder. You can see this great sheath of nerves that converge on the junction of the vagina and the uterus, where they're very vulnerable to injury during childbirth or straining on the toilet or different patterns of gynecological surgery. Now, what happened after 1945 was that increasing numbers of medical students had their undergraduate education take place on cadavers which were preserved in formalin, the yellow view here. And it's clear that formalin destroys autonomic nerves because the great sheath of nerves on the left has been reduced to numbers 8, 32 and 33. And this is a particularly good specimen, particularly good dissection of the pelvic autonomic nerves in formalin, but even then you can barely make out their morphology. Now, these nerves are very important, and as I say, they pass through the uterosacral ligaments to get to the uterus and fallopian tubes, and they get injured, and particularly in childbirth. If we take the two bottom panels first, these are both injuries that have been received in childbirth. Here, the uterus was almost ruptured through its posterior wall, but you can see the left uterosacral ligament is almost missing. The right, you can see through it. There's all these large vessels, varices we call them. And on the left, you can see that the left uterosacral ligament's been completely replaced by these big dilated veins. Here, you have these thin uterosacral ligaments, and these are caused by the uterus contracting too frequently, either as a result of the administration of misoprostol, prostaglandins, or oxytocin. And they literally tear the ligaments off their sacral origins, and it injures the nerves within the uterosacrals very dramatically indeed. Same when you strain on the toilet. Here you have these big, thick uterosacral ligaments, and this is usually part of a situation where there's fusion of the rectum to the vagina, big, thick uterosacral ligaments, and then all this ectopic endometrium pours out of the fallopian tubes. And this is for women that have trouble straining on the toilet, and not necessarily had any children, but they have definitely great difficulties with straining on the loo, and that renders them with a lot of difficulties, including pain and subfertility. When you look in the uterus, this is normal here, and you have to look in the uterus just where the uterosacral ligaments enter it, so in the isthmus. You can see that the lining of the womb here is separated from the muscle of the womb by this important layer of nerves, first described by Dr. Krantz in Kansas. But in all the other settings that we've already described, you see this aberrant reinnervation where large numbers of nerves sprout from the proximal nerve bundles after injury and give rise to all sorts of pain and difficulty and loss of function after their injury. I'll just draw your attention to this particular panel down here on the right, because this is the one characteristic of straining on the loo, and these nerves tend to surround narrowed arterioles. You can see this wall, the wall of this arteriole is thickened, the lumen is narrow, and you see these injured nerves which surround the vessel on this occasion, and that's the characteristic neurovascular injury, which is the hallmark of many obstetric and gynecological syndromes. This is a woman preoperatively with different degrees of adhesions and endometriosis, but look at the terrible situation postoperatively. I wouldn't want my pelvis reduced to this degree of damage with no certainty of outcome and no certainty that the pain is going to improve. This one's been done with a Da Vinci robot here, and it just beggars belief as to what's considered an appropriate restoration of the clinical anatomy in these circumstances. So for the last 15 years, we've been working on this, and you can see that, we first published this in 2005. We've discussed the injuries to the pelvic autonomic nerves, that 3 different causes that are largely preventable. But in the intervening period, there's been a great deal of new work, which also tends to support the neurological thesis, insofar as that women with endometriosis, with or without chronic pelvic pain, have adverse reproductive outcomes. They have much more preeclampsia, preterm labor, pregnancy loss of one description or another. And that's best explained by this comparison between over here, a arteriole, narrowed arteriole taken from a pregnant uterus, which is surrounded by this layer of pale empty cells, white empty cells, which are the sheaths of these injured nerves, which don't extend out of the pelvis in pregnancy, but the vessels and their sheaths do to the placental bed. And that gives us a clue as to what the source of most of these obstetric syndromes is, because it's this neurological injury in the woman's uterus which contributes to both this regeneration of injured nerves and the thickening of the arterioles. Secondly, a lot of these women with chronic pelvic pain, with or without endometriosis, have extrapelvic symptoms, nausea, vomiting, collapse, syncopal episodes, all sorts of things that can go on. This usually arises from viscerovisceral injuries or viscerovisceral reflexes, where the injury in the pelvis generates all sorts of neurological signaling, which is inappropriate and causes this distress. Inflammatory bowel disease is more common. The same segments, similar segments, or adjacent segments of the nervous system supply both the small and large bowel and the uterus and lower genital tract. So it's not surprising that if you were straining on the toilet, for example, you might just injure your T10 to 12 segments as well as your T8 and T9 segments. Same with the kidney, and much more likely to have hypertension and its complications. This is the situation described in this panel down at the bottom, which we'll discuss in another video. But they are T10 to L2, and the uterus is supplied by segments between the 10th thoracic and 2nd lumbar vertebra. Finally, a lot of these women have autoimmune diseases. We think that there's some evidence that straining on the toilet causes a primary denervatory injury with secondary autoantibodies, which cause not only the endometriosis, but some of these other autoimmune disorders. So compelling evidence for a neurological explanation for a lot of this chronic pelvic pain. And we think that this is a much better description of the syndrome, or one of many syndromes, because many women will present in many different ways, and that the ectopic endometrium is largely a bright, shiny red herring, which has been in play for 100 years and been a cruel hoax foisted on women to some degree, largely be out of ignorance of the role of pelvic autonomic nerves. So we think this is an important interpretation. We'd rather talk about chronic pelvic pain, which is the key symptom, rather than the sign of ectopic endometrium. There's no evidence that we can find that links deposits of ectopic endometrium with chronic pelvic pain. The three primary causes are the difficult first labors, straining on the loo, and different gynecological surgical maneuvers. All of these are preventable, and that the syndrome might best be approached simply by medical maneuvers such as MRI and ultrasound scanning, and then appropriate treatment to try and reduce the pelvic blood flow to avoid distending these injured nerves and causing a great deal of pain in the weeks leading in the week or two leading up to the menstrual period. So we think largely an epiphenomenon, largely preventable, and it's a shame that the gynecology has latched onto this appearance rather than the detailed anatomy of the pelvic autonomic nerves. There's reasons why that's become clear, simply because of the appearance of laparoscopy and the loss of the pelvic autonomic nerves in formalin preserved specimens. But even so, we should be moving to a much more appropriate interpretation of the clinical syndromes, because the woman's symptoms and her clinical course much better match injuries to pelvic autonomic nerves rather than these deposits of ectopic endometrium that excite so much interest amongst multidisciplinary surgeons and lead to all this extensive excisional and ablative surgery, which is of questionable benefit at the best of times. So I hope that's something novel, something new, a little bit controversial today, but we hope it's something you can reflect on before the next time we meet. With many thanks for your time listening to this. We'll see you next time.